Hi, everyone from around the world. I'd like to start off today with something that I would assert is relevant in both your personal and your professional spaces. And this is the concept of accuracy. If we take a look at this professional skateboarder that's looking to descend down this long ramp and ultimately to execute the trick, not only to what was prepared in the mind, but also to successfully be able to land that trick. If that individual were to look at that descent and have the wrong formula in terms of what the trajectory and the descent actually would be, then ultimately that could lead in disaster. Equally so, when we take a look at things in front of us, even if we choose not to believe the reality of what we see, that doesn't change what we potentially have to address. And accuracy can come down to something as trivial as a pole between failure and success. You see, if you're on the left side of this pole, the bathroom is 11 meters away to the bathroom is 11 meters away. And if you're on the right side, it is 10 meters away. And for those of you who are similar to myself and who have children, that could mean the difference between failure and success. So if we were to take a look at this concept of accuracy and bring it into our space and took a look at an individual like Chin, who presented with this type of occlusion, where we can see that there are areas of localized crossbites, missing teeth, areas of recession. When we take a look at the occlusal photos, we can also see that there is crowding on both the upper and the lower. Is it sufficient to say and make a decision just looking inside the mouth to determine whether we have a true arch length discrepancy where the arch circumference required exceeds the arch circumference available, and thereby the only way for us to actually fit the given volume of teeth within the given linear volume of bone is to be able to take out teeth? Do we also understand the infrastructure by which these teeth have to reside for the rest of the patient's life? Because you see, oftentimes we take a look at just the clinical crowns, where we recognize that the clinical crowns are associated with the root. They have to, in fact, actually exist in a symbiotic relationship with the underlying bone. And do we understand the infrastructure and the constraints by which we are able to move those teeth, such that when we take a look at an individual long-term, not only at the orthodontic finish do we see a healthy, static, and functional occlusion, but the roots are actually positioned in a way such that both the teeth and the occlusal forces will have a homogeneous or homeostatic relationship with the underlying bone. Because you can see in the orthodontic world, when we are completed our journey in terms of where the teeth actually need to move, what can happen is if we have not truly mitigated the risks, then over a longer period of time, the attachment apparatus may not be able to sustain that final positioning of the teeth. When an individual comes into our space, in just the first 10 minutes, they bring a plethora of information. The first is really, what is their motivating concern, which is also known as the chief concern. Because you see, individuals don't wake up just in the morning and say, hey, you know what? I want to go through the orthodontic journey and process, and I want a nice smile. There's a thought, a jog or a stride, if you will, into ultimately the action by which they will make the initiative effort to call and then also to come to the office to meet with you. And that chief concern ultimately becomes their motivating factor to not only acquiesce to treatment, but also to create the motivation that they're going to need during the compliance portion of their orthodontic care. Also, what are the obstacles to their ideal treatment? Dad says that look to histories to answers for the future. And what happens here is that when we are looking to help people say, yes, invest in orthodontics for themselves. We need to make sure that we're not remiss in understanding both the chief concern, the motivating factors by which they actually want to partake and pursue treatment, but also the challenges that could potentially create barriers for them to actually say yes. When we look at an individual intraorally, we can begin to get a qualitative assessment of really how they present. Does the lower and upper arch look normal? Does it look constricted? When we take a look at the arches, do we see spacing? Do we see crowding? How do we characterize that crowding and spacing? Can we qualify it as mild, moderate, severe? When we take a look at the overbite, do we see it as ideal? What does ideal actually mean? Because you see, when we have an individual that goes from orthodontic practice to orthodontic practice, or restorative practice to restorative practice, if we have differences in what our goals will be, then in the discipline of both art and science, we are favoring art too much and have strayed from science, where the only person that's confused at the end of that process is in fact the patient. We need to be rooted, no pun intended, in science, because that's what we are first. We are calculated, objective, measuring based professionals that are rooted in looking at mitigating risks, such that when we have our outcome, it's not only going to be stable for the moment that we ended the orthodontic journey, but it's going to be predictable, stable, and long term. When we take a look at the overjet, do we have anterior coupling? Do we have the lower teeth actually connecting with the upper teeth? And in what characteristic do we actually see that? Do we see that there is a presence of a crossbite? In the absence of a crossbite, do we see and suspect that if we were to upright and move those teeth, that in fact we would reveal an underlying crossbite? What is the molar classification? Is it 1? Is it 2? Or is it 3? Do we see it on one side? And what does 1 actually mean? When we go through our orthodontic textbooks, they had always shared that a molar classification 1 is what we ideally want to achieve. And the question is really, for me as an individual, why was that the case? And I'll share with you a little bit later in terms of what my question of the molar classification 1 was, and how I ultimately resolved that that is what we would look to achieve, and the reasons by which it ultimately helps the patient. Do we see any wear facets? And what is the excursive pattern? Do we see that it's canine guidance? Do we see that we have group function? And do we have any suspected non-working interferences? And the same with protrusion. Do we have mutually protected occlusion? On protrusion, do we actually have posterior disclusion? Also, what is the muscular health of the entire stomatic gnathic system? I like to share with our residents that there are 4 functioning systems. There is the skeletal, the muscular, the neural, and the dental. And at this moment in time, we're not able to draw blood and take a look at biomarkers in terms of which hosts are actually going to be susceptible to risks that are present and which ones are not. So in our world, when we are caring for our patients, if we are looking to really achieve the tenets of stability, longevity, and predictability, we have to look at every single individual as potentially susceptible. And as a result, when we are looking at not only diagnosing our cases, but also planning our orthodontic cases, we want to ensure that we are doing it in harmony of all 4 functioning systems. We also need to understand that we do require a symbiotic relationship in what is supporting the dentition. And that is the attachment apparatus itself. Do we have any muscular involvement by way of the frenum? What is the biotype? Is it normal? Is it thin? Is it thick? Because the reality of it is, when we take a look at the biotype, if somebody is thin, our envelope of discrepancy of tooth movement, the range by which we can actually camouflage a non-ideal scenario, is going to be very different than somebody that has a thick one. The same is true for recession. Do we see that there is recession that's present, and especially in the absence of any periodontal pathogen history? If that's the case, then we may want to suspect actually a tooth positioning or infrastructure issue. Do we see inflammation or any visible plaque? because the fastest way to attachment loss is running orthodontics in the presence of a biofilm. And of course, do we see fremitus or occlusal trauma? Because as we look to set up both the static and functional occlusion, we want to make sure that we have properly distributed the forces across the entire dental arch. And we can't be remiss in also looking at the joints. The lower teeth reside in the lower jaw and the lower mandible, which is a dual joint based bone, which has to articulate with the upper jaw and maxilla. So even if we're not taking CBCTs like we do on every single one of our patients, we want to make sure that we are completing a clinical joint exam, because that could preclude an individual, for example, from going forward with the treatment modality of clear aligners. And if we suspect that TMD is present or that they have predisposing factors to TMD, then we want to ensure that we inform the patient before they actually begin treatment of potential challenges that may occur. Because we always like to share that if we inform before somebody begins the journey, then it's an informed decision. If the instance or occurrence arises during the treatment, then potentially the patient will see it as an excuse. Also, if we are taking CBCTs, it makes sense to also look at the airway. And while there are two diametrically opposed positions on airway, what we like to share is that if you have the data point, we don't necessarily need to be the authority figure in airway, but we also don't need to dismiss the value of the information that we have, and also introducing the idea of what we are seeing. So going through the nasopharyngeal and the oropharyngeal space, looking at the rate limiting factor, which is the most constricted or narrow part of that airway, and sharing that back with the patient could ultimately help them to make a decision if they have any other clinical symptoms and signs of any sleep disordered breathing or otherwise, where they may want to have that conversation continued with other specialists in that space. And ultimately, what it comes down to is just in those 10 minutes, just in the 10 minutes of the information, 10 minutes that the patient presents all of that information, we need to be able to process it in a concise and a reliable way, which demands the notion of that our treatment planning process and diagnostic one ultimately has consistency, reliability, and is something that's pragmatic in our practice spaces. If we are looking at doing the due diligence that every patient requires, but it becomes disproportionate to the time, energy, and bandwidth that we have, then it becomes unusable. So our system and our approach is that we need to be able to have a streamlined effort where we are not diminishing the value of the information that is in front of us. And also, we are allowing ourselves an exhaustive treatment planning process to ensure that every part of that patient is taken into consideration. And then subsequent to that, once we have identified the etiologic factors, the associated diagnoses, and then subsequently the treatment plan that would support mitigating all of those risks, ultimately, we need a consistent and an efficient system that produces quality results. For us, that really is a synergistic pathway between the Prime Scan and the Sure Smile aligners. And for our community, our team, and our patients, this is ultimately what delivers on accuracy. And it's an expectation not only of our patients, but it's also for our team as well as ourselves. Jim Ron was a mentor figure to an individual by the name of Dale Carnegie. And for those of you who are not familiar with Dale Carnegie, he was a mentor for an individual that we all are familiar with, who is Warren Buffett. And what Warren Buffett had shared to a group of Columbia MBA students in a round table when prompted with this question: Mr. Buffett, if there was one course that you would highly recommend every single person take, in fact, let me clarify that even further, that you would find indisposable for every MBA student to take, which course would that be? Mr. Buffett went quick to the mic and he answered none of them. He said, instead, I would encourage you to read and follow Dale Carnegie. Because you see, when it comes down to business, it's really predicated upon interpersonal relationships. And Dale Carnegie's mentor was this figure, Jim Rohn, who was a true rags to riches individual. And he shared that accuracy builds credibility. And for our patients, what they are determining in the first moment that they are with us, when we are asserting that orthodontics is not only something that can help them, but it can truly reduce potential health challenges as they continue to grow. What they are looking for are what are potentially some quantified and objective methods that we are looking at to make that determination. And that's credibility from our patients, and equally as important is the individuals that decide to wake up every single day and willingly walk into our space, who is our team. And if it's not enough to garner the credibility from our team and our patients, let it be for you. My dear sisters and brothers across the world, it is my great blessing and privilege to spend this next moment together to discuss Orthodontic Diagnosis 101, the perfect clear aligner start. In full disclosure, this moment, this blessing is financially compensated, but I will share with all of you that the moment that we will have together is really what our patients, our community, and our team cherish every day and what we benefit from. It's up to all of you to determine the veracity of the words that come out in this moment. This is, in my world, a foundation for conversation. I know people call it lecturing, educating, and speaking. For me, it is none of those three. It's in fact a moment of sharing and in hopes, my dear brothers and sisters, that it could potentially help you, your teams, and ultimately the most important person in this entire process, which is the patient. And the foundation for our sharing and conversation, we need to dive into an important question. What is orthodontics? We'll walk through a prescriptive, a step-by-step orthodontic diagnostic pathway, which will not only serve as a platform and foundation for orthodontic diagnosis, but also on the flip side of it, it will be our script for ultimately how we orthodontically treatment plan all of our cases. And then the final thing is, it is important and behooves all of us to talk about really what is the orthodontic value proposition. So in the 30 seconds that we have to pitch the idea of orthodontics, how do we come out of this narrative that's being propagated within our community and potentially within our profession that orthodontics is just a cosmetic and a aesthetic procedure and outcome? So when we take a look at orthodontics, the question we need to ask ourselves fundamentally is, what is orthodontics? And I would assert to all of you that you are already experts in orthodontics. And very simply put, orthodontics is full mouth reconstruction of the enamel. So for some of you in the restorative space, if you are looking at orthodontics, if you are looking at full mouth reconstruction with local anesthesia and crown preps and restorative materials, in the orthodontics world, we fear the needle, and instead what we look to do is just move the teeth. The principles of occlusion still remain the same when we look at the static bite as much as we do the functional one. We want to ensure that the teeth are coming together not only in a meaningful way, but when we take a look at the underlying roots, that we are respecting both the envelope of discrepancy of the teeth, where the teeth can be moved, as much as the skeleton underneath that is supporting it. So before we actually look at the value of optimally functioning systems, we thought it prudent to share what it looks like for suboptimally functioning systems. And what we're about to share is something that we all routinely do multiple times a day, every day of the year, which is eating. This individual came in for the relapse of tooth number 10, the upper left 2, where it seems that it's an easy fix to be able to orthodontically move that tooth back into position. When given a piece of lettuce to chew, we see something quite remarkable. As she's chewing, you can see in that chewing cycle, she's grinding against the edges of her teeth. Most prominently here, we can see against the right canines and catching part of the distal of the upper right 2, or tooth number 7. If we take a look on the left side over here, we can see the chewing stroke grinding against the canines and also catching the distal of the upper left 2, or tooth number 10. So while it seems like tooth number 10 just relapsed to the mesial, we can see that the adverse forces of the chewing stroke actually was the etiologic factor by which that relapse occurred. So if we were to just move the tooth and be dismissive of what dad says, which is look to history for answers for the future, then what the patient could potentially have is a etiologic factor or risk factor that's still present post second round of ortho, which can cause the relapse. Instead, this is in fact actually an ortho restorative case. Once we have truly understood the hallmarks or the salient features of a sound occlusion, we are then able to properly position the teeth and in conjunction with restorative, enable a functioning environment where consistently the patient can healthily actually be able to go through the masticatory process without any detriment to the 4 systems, which are the neural, the muscular, the skeletal, and the dental. So it now is our obligation to ultimately determine and discern what are the key hallmarks for occlusion. And while this space is quite vast, we found that there is a landmark article, which is a staple in every single orthodontic residency and orthodontic team experience, which is Larry Andrews' 6 keys to normal occlusion, and has not only changed the way that we look at orthodontics, but has also withstood the test of time. And this is going to be our prescriptive pathway in looking at occlusion, not only diagnosing our cases, but ultimately what are the key features in the setups that are returned to us that we should be looking for, that every single patient should be meeting. So Dr. Andrews looked at 120 non-orthodontic normal models, which is really the control group, and then 1,150 orthodontic treated models, which is the sample. And what he found is that there were 6 consistent attributes across every single person that constituted a healthy bite. And we're going to go through each of those. Key number 1 was the molar relationship. The mesiobuccal cusp of the upper should engage in the mesiobuccal groove of the lower first permanent molar. This, as many of you are aware of, is Angles classification 1. And one of the questions that I had to myself is that, while we have deference to our faculty and to the textbooks and the people that came before us, I am a researcher. I went to Penn University of Pennsylvania my entire life. I had a focus in bone biology, did my master's there as well. In the mind of a researcher, I trust everything, but I don't trust anything. And in one moment, in one evening, I woke up and I said to myself, well, why am I blindly just following Angles Classification 1? As I thought through that process, I started to think about a zipper. And I'm going to make this a rhetorical question based on the platform that we are in, which is Zoom. But how many people this morning thought of your zipper? Generally speaking, we don't think of our zipper on a very frequent basis. And really the only time that we may actually think of that zipper is when it doesn't work. And the reason by which the zipper is an unremarkable experience is because if the zipper is lined up properly, each of the sides, the right and the left, are proportionate to each other. Every time we close the zipper, open the zipper, close the zipper, open the zipper, it functions uneventfully. The same is exactly true for our mouth zipper. If we have the right starting position where the mesiobuccal cusp of the upper is engaging in the mesiobuccal groove of the lower, everything mesial or subsequent to that, the second premolar, the first premolars, and the canines will line up exactly where they need to be. More specifically, then the maxillary second premolar will engage in the embrasure space of the mandibular second premolar and the mandibular first molar. Mesial to that, the maxillary premolar, first premolar will engage in the embrasure space between the mandibular first premolar and the mandibular second premolar. And then the canine, maxillary canine, will land right in the embrasure space between the mandibular canine and the mandibular first premolar. And for those of you who subscribe to canine guidance, that's exactly where you would want the maxillary canine. And this is one of the reasons why Angles classification sets up the occlusion all the way through the dental arch. And you may now already be thinking, this is why identifying two size discrepancy becomes so important. Because if we have a zipper where a few parts of that zipper are undersized, then the zipper cannot work efficiently, predictably, and stably every single time. And such is true with our mouth zippers. The reason it can work every single time is not only do we have the right starting position, which is the molar angle classification 1, everything subsequent to that will land exactly where it needs to be if there are no two size discrepancies. Key number 2 is the crown angulation and tip. And what we are sharing here is that the posterior teeth, the occlusal or the incisal edge of the posterior teeth should be slightly mesially inclined compared to the gingival or the cervical portion of the teeth. And the reason for that is if we are looking at something like canine guidance, then we want to catch the mesial part of the maxillary canine against the distal part of the mandibular canine. If it was upright, then what will most likely happen, you'll slide into group function, or you'll get lateral protrusive participation from the lower anterior teeth. Second to that, if you have truly upright or vertical teeth, then what you will begin to see is that you will have occlusal edges of the posterior teeth accelerate in their wear because they would not be able to withstand the lateral excursive forces. Key number 3 is broken down into 2 parts. Key number 3, part number 1, is that the upper and the lower anterior teeth need to have positive torque. The upper and the lower anterior teeth need to have positive torque. In fact, in our world, we actually want the uppers to have 57 degrees of positive torque compared to the occlusal plane, and the lower needs to be 72 degrees to the occlusal plane. Not something that you necessarily need to actually measure out to the degree and specificity that we do every single time, but we want to make sure that they are procline. The reason for that is the resulting angle between the upper and the lower anterior teeth. The resulting angle between the upper and the lower properly proclined or torqued teeth will mimic the angle of descent of the joint against the anterior part of the fossa. The resulting angle of the upper and the lower anterior teeth will oftentimes mimic the angle of descent of the joint against the anterior part of the fossa. Key number 3, part number 2, is that we want to have the posterior teeth to be upright or slightly lingually inclined. We want the posterior teeth to be upright or slightly lingually inclined. And this is really the curve of Spee. And what we're looking at here is that we want to make sure that the palatal and the buccal cusp are going to be on the same plane, or that the palatal cusp will be at most 1 millimeter inferior to the buccal cusp. This will ensure that we have no non-working interferences. So if we take a look at this patient, and this patient were to move towards the left side, so a left working movement, if we don't have an idealized curve of Wilson where the palatal or the lingual and the buccal cusp are in the same plane, and that lingual cusp is below the buccal cusp, you would have a non-working interference. And what happens here is that generally when people are speaking or eating, they just can't slow down their speech or their eating and then all of a sudden accelerate. They have to be able to speak on command as well as eat on command. And the only way that the body knows how to be able to get around a non-working interference is it has to speed downwards, so it translates the joint down around the non-working interference, brings the entire mandible back up into the right position for a continued working movement to that left side. Inevitably, what will happen is the contralateral canines will slam in on each other as they tries to pick up the canine guidance, and you'll see excessive wear on those contralateral canines, and the body continues to move on. So if we want to avoid these non-working interferences, we want to ensure that we have an idealized curve of Wilson. Key number 4 is the absence of rotations. How do we actually ensure that there is indeed an absence of rotation? When we take a look at the teeth, are we looking at the middle of the incisal and the occlusal edges to make that determination? Are we looking at the lingual aspect to make that determination? Or are we looking at the facial aspect? American Board of Orthodontics takes a look at the absence or the presence of a rotation by looking at what's called the incisofacial edge. If it hasn't happened to you at this point in time, it will. It's a matter of if, not when. A patient will run their tongue on the inside post-orthodontics and say, well, hey, I know that things look aligned and it looks aesthetic, but when I run my tongue on the inside, it feels bumpy. So I don't think that it is fully where everything is fully where it needs to be. And of course, we understand that there's going to be a difference in facial-lingual dimension across all of the different teeth. Just if you went from the transition from a canine to a lateral incisor. So when we are actually taking a look at the absence of rotations and share back to our patients, well, I can completely appreciate when you run your tongue on the lingual part or the inside that you feel it's bumpy, but we are looking at an objective way to be able to measure that rotations don't exist. Accuracy builds credibility. And if we share that the incisofacial edge is really the determinant by which we can discern whether a rotation exists or not, then the patient will begin to understand that this is not something that is a subjective decision. It's objectified. So how do we go back tomorrow? And how do we calibrate ourselves in understanding what this looks like. The best way to do so is to take a sharp pencil and a cast. If you have a 3D printer, that's completely fine. You can use a 3D printed model, or if you have stone models, that works as well. It takes really just an iteration of 1 or 2 times to fully get calibrated in terms of how to see the presence of a rotation. So what you'll do is you'll take the edge of the pencil, and it's not the tip, it's the edge, and run it across the incisal-facial edge of the entire dentition on the upper arch, and then the same would be true on the lower arch. What you are then looking for is that, do you see a continuous arch all the way through, or do you see that there's a deviation or a break in one part of that arch, which would signify that in fact you have a rotation that is present? And then when sharing back to the patient that I can understand how you may want some of these teeth moved based on what you're feeling. But when we look at what a healthy bite is, and when we are reviewing your scenario and sharing that there are no rotations that are present, if we were to move a tooth out of position, the one that you were suggesting, just realize that we would be moving it out of a non-ideal scenario. And a majority of the time, when the patients begin to realize that, in fact, you are speaking from a position of objectivity, then they will respond back, well, that makes sense. I prefer to have this ideal and healthy scenario versus the one that I thought in my mind was the one that I needed. Key number 5 is no spaces and tight contacts. And of course, that is quite easy if we go through the orthodontic journey and check at the end of that journey with floss that we have everything nice and tight. Well, the reality of it is, how many of us actually want to go through an entire orthodontic journey that was planned in a digital orthodontic workflow, for example, like us in the Sure Smile system, and at the end of the journey, let's say it's 2 years, at the end of the journey, take floss and find out that we have space. That's a no-go for us. Instead, we want to ensure that in our digital workflow platform, that we have some type of mechanism to ensure that there is going to be no planned space at the end, and then ultimately our clear aligner system delivers no space. The same is true on the flip side. For example, if we have a tooth size discrepancy on the maxillary lateral incisors, whenever we plan our cases out, if we're running it a la West Coast, Dr. Kokich style or philosophy, where we want the space to be distributed 1/3 on the mesial, 2/3 on the distal for post-ortho restorative, or East Coast, where we possibly want it 50-50. We want to make sure that space is planned out before we actually begin that clear aligner journey. And we want to be able to see what that space distribution is in terms of the magnitude of how it is actually allocated. And then the final part is we want to make sure that we have a flat occlusal plane, or Dr. Andrews said that the occlusal plane should be at most 1 millimeter of curve of speed depth. This will then round out our entire static and functional occlusion to ensure that we have mutually protected occlusion. If we have a flat occlusal plane, or at most 1 millimeter curve of speed depth, when the patient goes in protrusion, they will have posterior disclusion. You see, in the orthodontic world, I can't have enough of an understanding where I'm looking at cusp heights, if the posterior cusp heights are tall or short or flat or normal or medium, in terms of what the posterior disclusion pathway needs to be. If we keep a flat occlusal plane, 1 millimeter curve of speed depth at most, we will always ensure, despite what that patient has in terms of their cusp height, that they will have posterior disclusion on protrusion. So these 6 keys ultimately can become your diagnosis for your cases. How does your patient deviate from the norm? And also, it can be your prescriptive step-by-step pathway when you are treatment planning your cases. So you can take a look at each one of those keys and ensure that you have achieved them. And of course, if you had a skeletal class 2 relationship where you're going to maintain the skeletal class 2, then you would look to really achieve keys 2 through 6 and recognize key 1 wouldn't be possible. So as a friendly recap, key number 1 is the molar relationship that the mesial-buccal cusp needs to engage in the mesial-buccal groove of the first permanent molars. Everything mesial or subsequent to that will then properly line up such that the maxillary canine will land in the embrasure space between the mandibular canine and the mandibular first premolar. Key number 2 is the crown angulation. We want to ensure that the tip of the posterior teeth is such that the incisal edge is going to be mesial to the gingival portion. Key number 3 is the crown inclination, broken into 2 parts. Part number 1 is that we want the anterior teeth to have positive torque, which ultimately is going to be the runway and is going to mimic the angle of joint descent against the anterior part of the fossa. Key number 3, part number 2, is that we want the posterior teeth to be upright or slightly lingually inclined, idealizing the curve of Wilson, ensuring that we have no non-working interferences. Key number 4 is no rotations. The absence of rotations is determined by looking at the incisofascial edge. Key number 5 is no spaces. We want to ensure that our clear aligner software can properly dictate or delineate the fact that no spaces are planned for, and ultimately that's in fact what we deliver on. If we have a 2-size discrepancy, we want to be able to see how those spaces are ultimately proportioned out. Key number 6 is a flat occlusal plane. We want to ensure that at most that curve of speed depth is going to be 1 millimeter or completely flat. Want to share this patient that is about 5 hours away from our office so she has a 5-hour journey each way, and this is what her presentation was. So when we look at the power of Andrew's 6 keys, we want to bring it to this case. Now, while we look at several hundred factors orthodontically of what the patient presents, just breaking it down into the 6 keys, we can see not only from a diagnostic perspective how she deviates from the norm, but then also it becomes our prescriptive pathway in terms of what our end goals for her would be. So if we take a look at key number 1, the molar relationship, we know that that mesial-buccal cusp should engage in the mesial-buccal groove. And in her case, we can see that the mesial-buccal cusp of the upper is mesial to the mesial-buccal groove of the lower. Everything in front or anterior to the molars are now off in terms of their position. So the second premolar, the first premolars, and the canines are all in a class 2 relationship. If we take a look at key number 2, and just looking at a few teeth, on the left side, we can see that the upper left 3 or the upper left canine has the incisal edge distally tipped compared to the gingival portion. Also, we can see that while the upper left first premolar and the upper left second premolar are slightly mesial tipped, they are divergent in what their actual crown angulation is. We want to make sure that they are parallel, and of course, getting the things like the upper left canine in a better position where it is mesially tipped at the incisal edge versus the gingival portion. Key number 3, part number 1, is that the upper anterior teeth should be positively torqued, but in this case, you can see that they are clearly retroclined. If we take a look at key number 3, part number 2, we can see that the posterior teeth are lingually inclined, but they're excessively lingually inclined. If we take a look at a coronal section through those molars, we can see not only they're lingually inclined, take a look at these lower molars, we can see that they're violating the buccal cortex. So we want to not only upright these teeth, but we also want to make sure that we center them in the bone. If we take a look at key number 4, rotations, without even the calibration using the pencil, taking a look at the incisal-facial edges, we can clearly see that in her case, there are rotations that exist. We can also see in key number 5, there are spaces that are there, and this is a orthodontic and restorative case. If we want the oral zipper to work in an unremarkable way every single time, then that would be predicated not only on positioning the molar into the right position, and then everything mesial to that will fall into place, but we need to ensure that everything is proportional across all of the upper teeth as well as across the lower teeth. Key number 6 is a flat occlusal plane, and that is something that she presented with. So this was her initial, and ultimately this was her final. We took her from beginning to end in 16 months. And really, when an individual drives that far in our space, we feel a huge sense of obligation to ensure that not only are we understanding the outset of this journey and where the point of origin is, but equally as much we want to know where the point of destination would be, and ensure that we have efficiency built in the entire journey in between. This is the initial and ultimately the finish. So one of the things that I didn't share is that, in fact, this is not only an orthodontic and restorative case, but it is an orthodontic and surgical and restorative case. She needed a BSSO, a 9.6 millimeter advancement of the lower, as well as a 2.6 millimeter counterclockwise rotation. And you can see here, by applying Andrew's 6 keys, how we can understand in a simple yet undiminished and profound manner really what the needs were for her, and ultimately determine what our goals would be at the end, so that we were able to take an individual like this ultimately to finish like this. And in this moment, in this blessed moment in sharing, what we were able to understand is that we are all masters of the field of orthodontics. And that is because we have a strong command of really how bites need to be designed. And where we may be taking local anesthesia, crown preps, and restorative materials to do full mouth rehabilitation in the world of orthodontics, we are identifying and ultimately treating to ideal, healthy, engineered bites by moving teeth. We are just completing full mouth reconstruction by way of the enamel. And what's true for us all is that there are a myriad and plethora of orthodontic technologies that are out there in the space. But the markets drive our sensitivity in terms of treatment modalities that we have to entertain. And the reality of it is that clear aligners are the choice of the market today. They are driving the idea of orthodontics needing to fit an individual's quality of life without any diminished outcomes of the healthcare that they are receiving. And where we may have looked at clear aligners and the companies just being this easy button or click button solution, the reality of it is, if we want to still be relevant as healthcare practitioners, the individuals that we are, people that are rooted in prevention, then we must be founded in scientific diagnosis and scientific planning. Our end output can have our artistic signature by which our patients will love their smile for the rest of their lives. But fundamentally, the reason by which they will have the smile for the rest of their lives is because it was founded on scientific principles. And that is by which my brothers and sisters, the Andrew 6 keys, deliver every single time. So that brings us to the orthodontic value proposition. How do we share with individuals in a concise way that this is a healthcare driven solution? Because you see, if we make it an elective discourse or propagate rhetoric that this is an elective decision, then it is not an elective decision between different practices that they're choosing from. It is, in fact, an elective decision between life elective decisions that they have, whether it's choosing the next car or upgrading the cabinetry in their kitchen against what is quote unquote the elective smile that they have. So the way that we share the orthodontic value proposition is that if you were to take a bridge from point A to point B, point B to point A, point A to point B, point B to point A, every single time, the reason that's an unremarkable experience and one that you trust that it will deliver on your journey back and forth is because it's predicated upon a sound physics infrastructure. And that is exactly what orthodontics is. It is a sound physics infrastructure, and the byproduct of that is a lifelong smile that you will truly love. This is our entire digital orthodontic workflow. We take CBCTs on everybody, take our prime scan, which is our digital impression, push it through multiple orthodontic softwares, ultimately into the Sure Smile system with an output of a treatment modality that delivers every single time for us, our patients, our community, and our team through the Sure Smile aligners. But it's always founded upon an understanding of the correct etiologic factors, which is the diagnosis, and ultimately a sound treatment planning process. And this is where we are able to deliver accuracy every single time, and where accuracy builds credibility, like Jim Ron said, because it's an expectation of our patients, our team, as well as all of us. If you're interested in learning more about the clear aligner process and journey, there is a great resource on the Sure Smile interface. If you have your phones with you and pull up the camera function without taking a picture, if you just let it hover on there, on the right is a QR code, and that will take you a link to the app that will be able to help you engage with the Sure Smile University, where we have many other videos beyond just Orthodontic Diagnosis 101. My dear brothers and sisters, as you go and look to spread smiles across the world, helping people not only smile on their faces, but to also smile within their hearts, I hope that you continue to do so with the most powerful force in this world, which is love. I am grateful for this blessing to share this moment, this time, this opportunity with all of you, my dear brothers and sisters, and to pause for a moment from my nuclear family to virtually connect with all of you and to be able to call you my family. I also want to pause in this moment to provide my sincerest gratitude to Dentsply and Viva for facilitating this type of sharing and this opportunity, in hopes that collectively, as one and with one love, we can share smiles that people will enjoy for the rest of their lives. I'd be happy to take any questions that all of you may have. If you don't mind utilizing the Q&A function, I will take a look in there, and then I'm happy to answer any questions that you have. So one of the questions was, when you flatten the curve of speed, does it affect the molar dental relationship a little? Not only the molar dental relationship, my friend, it can also affect the relationship in terms of how all of the teeth line up. But that's not a reason not to actually flatten the curve of speed. Really, if you're affecting the molar or tooth position relationship, then you are looking at actually moving those teeth to where they need to be, in addition to flattening the curve of speed. We don't want to leave an ideal occlusion in just an angles classification while also leaving a risk factor when we're moving in our excursive movements. How do you close the posterior open bite with clear aligner on our patients? If your posterior open bite is in fact one that is skeletal in nature, that would be outside the purview of clear aligners. In fact, outside the purview and ability of braces as well, because that is skeletal in nature. The question is, if a patient actually presents with the posterior open bite and you can't explain what you're seeing in that posterior open bite, my recommendation would be that an orthodontic team should be looking at evaluating that. If the posterior open bite is in fact a sequela of your clear aligner treatment, there are two different approaches that I would recommend. Number one is that posterior open bite, since it was not present at the outset of the journey and only resulted at the end of it, should it not have been a planned treatment, is transient in nature. Run your retainers for a short period, only canine to canine on the upper and the lower, running in Essex with nothing in the posterior, seeing the patient every 2 weeks, and you will see that that will settle into place. If you have somebody that has a brachycephalic, very strong musculature, then one of the options is, in your case design, to put horizontal rectangle attachments in the posterior. That will allow the aligner to grip the teeth, and ultimately through the increased mascatory forces, you will actually have a mechanism in place to avoid the adverse forces that could potentially create that transient intrusive effect. My sister Ashley, I appreciate your moment of gratitude and your pause to share that. The blessing is truly mine. Is there any difference in the prognosis by treatment with fixed braces versus clear aligners in aged patients, for example, 40 plus? Anuja, I gotta say, well, you just threw me in that aged group because I'm 40 plus, but mentally I feel like a 21-year-old. So the answer is no, there is no difference. In fact, they're just two different treatment modalities. It's two different cars if somebody was driving a Honda versus an Acura. But what is true is that not every treatment modality can treat every case. Clear aligners do have certain preclusions for certain types of movements. So it's not age dependent at all. You just want to make sure that we are selecting the right candidates that are going to be successful every single time that we employ clear aligners. What is beautiful about clear aligners is that they're going to always be within the therapeutic range to be able to move teeth, which is 50 grams to 150 grams of force. We cannot create smoke and mirror and magic with braces, that's any different than clear aligners. We are founded in science, whether we're using clear aligners or in fact we are using braces. What kind of retainers do we use after treatment with each? Well, this comes down to actually case diagnosis. So I will share kind of a 30,000 foot level of our retention program, but we do have kind of a 4-day program that we do with CDocs that really goes into all of the details about retention choice. But the 30,000 foot level is we look to place fixed lower retention 3 to 3. On our adults, it is an upper night guard, and on the lower is a spring aligner. For our children, it is fixed lower 3 to 3s, upper hollies with Adams class on the upper 6s or first molars, with a labial bow 3 to 3, and then a spring aligner on the lower. For both our adults and our children, our spring aligner design is Adams class on the 6s or the lower first permanent molars, and the active labial bow on the lower 3 to 3. My dear brothers and sisters, it looks like we have just hit that 1 hour mark. I cannot stress enough to all of you that this was my moment's greatest blessing, to be able to engage with each of you. While I didn't get the moment of seeing all of your faces, I felt all of your energy. May you move forward with love and as one, as we all collectively come together to share smiles across the world. Thank you all again. Stay blessed. I want to also take a moment to thank Trung, who helped facilitate today's virtual experience, and a gratitude moment to both Dentsply and Viva. Wishing you all lots of love, happiness, and blessings. Thank you.